Flower girl. She's wedding at the same time.
I told you.
Good.
I've got 3 daughters, so I know what you mean. They're very much the same.
I Did you know each other from?
We worked together
What?
20. How many years ago? 22. Only a few. 23. Long time ago. Yeah. And I go let them know that they can come up with that upset. Yeah, a long time ago. That's quickly.
You bring your family over for the summer?
My wife's here. She's done completed 20,000 steps today. And she's walked all the way into.
But they're
the
they're in the States with you?
Oh no, so it's just my wife and myself, and I've got a I've got a 14-year-old daughter called Grace, and just only 3 days ago, Sophia, who's just turned 16. So she's texting me because it's, I don't know, 10 o'clock in the morning. And then she keeps throwing this list of things that she wants from Melvin. No, there's a shop called, I don't know.
Brandy Melville.
That's this one. Yeah.
What is it?
Brandy Melville. I think
Brandy Melville? Yeah, yeah. And I don't even know what it is.
Is that where that's from?
Oh, really? So I've got this list of Brandy Melville, and then I've got a 18-year-old who's about to be 19, but she's doing a course placement in Queensland in Australia.
Okay.
Yep. So they're just the whole thing.
They're in school. They'll be at school while you're here.
Yeah, correct. Yep. Yeah. So it's just going from.
Oh,
It's almost the same weather.
Yes.
It's almost the same weather at home as it is here, because we're changing it's going the wrong way. So it's getting dark and it's getting cold. And it's just not so nice.
Oh wow!
So-
So you're gonna have a year with no.
He
No
went
winter?
for a few years, did it
Wow,
again.
nice.
Oh, so he's been working full time in construction. Yeah, absolutely, absolutely. That's so great. When you like know what you want to do.
Sure.
Yes, and he actually said she was talking. Really? Yeah. He was near
Like,
school.
yeah,
She was
this
walking.
was really near.
Yeah,
school.
they're
So I'm gonna take this
yeah.
to the post office, bro. He's doing some kind of online course, so I have a little more credit.
So, yeah. What about you?
Well, I'm in 8th grade now, but
Okay, you're,
yeah.
where's your sister going?
Oh, yeah, that was what a journey. She's going to Maryland.
Yeah. My niece will be overly, yeah. But she's.
It's very March.
Yeah. State school, but not our state, but.
My shoulders are a little bit bigger, aren't they?
Sorry, just catching up. We
Oh, no,
didn't know we
that's
had
good.
to run into each other.
Good evening, everybody. I'm Luke from Post Physical Therapy. We're putting on a program and an information evening tonight. This is Jeffrey. He's from New Zealand. Full name is Jeffrey Potts. For the last 6 months, we've been working on developing a program that creates a data-driven model to show people how their knees are at risk for injury. ACL and knee injuries in our youth are far, far too prevalent. And so we've identified a significant need for a testing program to show risk, to show you how we can reduce that risk. Brought Jeff from New Zealand to lead this program. Jeff is a specialist physical therapist in knee care. He's the only one in New Zealand. Requires hundreds of hours of dedication. Jeff is a researcher, he's a physical therapist, he's a lecturer, and all of that combined gets him the title of knee specialist. Jeff has previously worked with the pinnacle of New Zealand sports teams, which is New Zealand All Blacks Sevens team. Jeff is incredibly well respected within the industry. I'm very proud to have him here. Jeff is going to talk to you about what this program is, why you need it, and how we're going to implement it. Jeffrey.
It's very nice words. So the idea really is not to bombard you as a academic lecture, because that's not all that interesting. It's always about statistics and things that researchers really enjoy. It's more to talk to you sort of as an adult, as another parent, because I was just talking before, I've got, I don't know, good fortune or blessed or sometimes misfortune. Sometimes I have 3 daughters and they are of a similar age that we're going to talk about today. So I have a bit of a vested interest in this whole process. And I think one of the key things to get across is maybe explain to you what a normal ACL injury and journey really does look like. Because I see this in my work every day. I see fresh injuries. Had a couple last week of a young 16, 17-year-old woman. And then I see them 1 year later, 5, 10. I see that same person 20, 30 years later, and it has a consequence. And in literature, so if you want to get really scientific about it, it's been classified as an epidemic, which is a slightly provocative word. And we'll go through this whole journey together, and then we can maybe answer some questions near the end of it. As Luke had talked about, how can you trust what I say? Hopefully you trust what I say. My background, to attain a specialist qualification, it's about 10 years of work, and it's particularly focused on what's classified as lower limb. So knees are my passion. I dream about knees, which is slightly weird, but I love it. And part of my research has been about, or always about, ACLs and then altering the trajectory, trying to make things better. And so we do that sometimes with, if somebody's about to have surgery, we'll do certain exercises for them to make them, to produce a better outcome long term. So there's some things we can do. We can also try and implement best practice, and this is a really key message across this series tonight, that implementation, like doing what is recommended, is really key. You can have all the data you like and all the information you like, but implementing things is a really, really key thing to do. It's not often followed. So lots of years of training, quite a specialized clinic, and I see thousands literally of ACLs on a yearly basis within my practice. So I think what we'll do is we'll start at the beginning. We'll explain what an ACL is, how they become injured, what that trajectory, what that journey looks like, and then we'll talk about some prevention programs. We'll be able to link it all back together again. This will be a good test of my computer skills. Here we go. So I tried picking pictures that aren't too grotesque. I had a video to display to you of how an injury happened, but it gets a bit squeezy, so we left that one out. So the idea is that you have a knee, you have a shin bone and a thigh bone, and this is almost graphical, but you have four really big ligaments in your knee. You have a ligament on the inside of your knee and a ligament on the outside, and that stops your knee going left and right. And then the thing we're going to be talking about mostly today is the yellow drawing. It's called your ACL. And what it does is it stops your shin bone moving forward too much or uncontrollably, or twisting at your shin as well. If you damage that ligament, it will make your knee what's called mechanically unstable. So it just doesn't work or move like it should do. The way in which these injuries occur are described, they describe a catastrophic knee giving way. Classically, somebody will be running, they try to change direction, they stop, they try and dodge an opponent. This is familiar. It's a classic for football, for basketball, for any sport where you're trying to decelerate or change direction quickly. And there's what's called a classical presentation. So often people will hear or describe a pop or a snap with that movement. and then potentially lots of swelling and a sense of giving way. They don't trust their knee. It's a significant event. So 80% of people who go on for surgery will turn up to an A&E to a doctor within 24 hours. So it's not a small incident, it's something that's meaningful for them. So they're motivated by pain or instability. That's a traumatic process. The key part today is that when we look at that process, if we look at the people who are engaged in that process, there's a big change over time in young women. So young women particularly have a higher incidence. Got 2 screens to work with. So how often, how much does this kind of happen? Is it really that important? Like, are there very few of these? When we look at the science and the data behind it, there's lots and lots and lots of them. So in the US alone, so sometimes I drag in some data from New Zealand, but we're a really, really small population. We only have 5.5 million people. So it's tiny in comparison to the US. But in the US, there's 1 ACL rupture per 3,500 people per year. When we talk about that, pretty good odds, 1 in 3,500. But when you wipe out, I don't know, a 40-year-old and above, that's a big chunk of the population. When you do the stats on it, it becomes quite intimate and quite close. So there's about a quarter of a million, so 250,000 of these per annum every year in the US. And these are the ones that are just reported and that are then notified and then go on to surgery. And so every year, this goes on and on and on. And part of my motivation I talked about before is I get to see them when they're fresh, and I get to see them as they traject over time, and they have some pretty big impacts in your life over time. One of the key messages for today is that as of the late 1990s, maybe the early 2000s, when we were collecting lots of data on ACLs, and they're called an ACL registry. So this is a group of people, and in the US, it's insurance companies, but in New Zealand and Australia and through Europe, the surgeons count how many ACLs they have. And so for many, many years, it's called incidence and prevalence, which is just a count. It's a statistic it's what scientists love. They count how many people have these injuries. And around the early 2000s, there was a really big, consistent jump increase over time. And this is where it's become a bit more intimate for me, that my daughters represent this group. So it's about 120% increase in a decade. So the numbers just go up and up and up and up, almost exponentially in young women. And when we look at young women, when we classify them, they're probably 13 to 14, up to about 19, 20 years of age. So smack bang in the cohort of my daughters who play all these sorts of sports. That rate went up so much that they started to investigate these injuries a bit more. And this is where the epidemic scenario came from. When we look at, again, the numbers, that young women are 8 times more likely to rupture the ACL than an age matched young male. And there's a few reasons for that we'll go over soon. So there's lots of them. So these things are, just to pull this together, these are traumatic accidents. Young women are statistically more likely to suffer from these. And there's been a large increase in their presentation over quite a short period of time. And we look at why that's happened. And I think again about my daughters, they've been encouraged to play sport more, participation's increased. Sport has become a vehicle for success for some. They look for professional avenues or scholarships like my children do. And so they've been encouraged to participate more and more and more. But then unfortunately, this data shows it's a huge increase in a higher likelihood of the young lady's going to have an injury. At a scientific, this is the stuff that I do for work. This is the research component on the side. We like to understand why these things happen. And these are some photos from some hallmark studies that were actually completed here in the US. And there have been some groups of athletes, some young men and some young women who have been conveniently tested. This is at the beginning of the season. They're volunteered and they've been screened and tested. And then they watch them over time. And there's an unlucky few, the 1 in 3,500 that rupture their ACL. And then they can go back over time and then find some things that might have been going on, and they can work out whether these are attributed to their injuries or not. So at a scientific level, these are called modifiable risk factors. And this is what we deal with the most. So the next screen, there's a modifiable component that's something we could work with. And there's a non-modifiable component that you can't change. Now, modifiable, things like strength, things like how you jump and how you land. And why these are relevant, this is how these injuries occur. So we go back to the beginning, how it happened. Maybe a young woman, one of my children, played field hockey, which I think is a pretty decent sport here in the US. So field hockey requires rapid changing of direction or accelerating after an opponent or defensively trying to stop really quickly and change direction. And so again, when you plant your foot and try and change direction when someone's trying to step you, that movement, if you're not strong enough or not coordinated enough, the whole leg twists, and it's called a valgus deformity. It twists and rotates, and the ligament just goes, and it's that ligament we saw at the beginning that was yellow, and it's the biggest, thickest, meanest, best ligament in your knee, and if you break that part, it hurts. There are several, this is just a brief list of the modifiable parts. So young women are not small men. And we think this is where maybe some of the research was missed, maybe in the early 2000s, that a lot of time and effort was spent on young male soccer players or NFL players or basketball players. Was more interested in researching them, which I find really weird. I'm a feminist because I've got 3 daughters, but there was all this research that really focused on guys, and they are not the same as a young woman. And so we found that there's some really unique things in young female athletes where muscle coordination is really, really important. And if your muscles don't coordinate properly, that is a very big risk factor in your knee. So muscles are meant to work together to reduce this movement in your knee. And again, this cohort, this young female group, those muscles don't always coordinate properly. The good thing is they are trainable. So that's why they're classified as modifiable. When we look at reducing, this is a bit of a punchline, when we look at reducing the incidence of these modifiable injuries, we can reduce it by at least 70%. It's a lot, it's huge. It's a really important part that if we can identify what is maybe not working optimally and correct that part, then injury frequency or incidence reduces massively. For completeness, I could write a big list similarly about non-modifiable, and this applies to both genders. We think there are 2 genders, that there's some bone structure that you can't control or can't change for, and actually you don't find out about that until maybe you've broken your leg. But they're called anatomical factors, where the shin bone is of a particular shape that's very easy for the bones to slide off each other, or you have a very, very thin, weakened ACL anyway, but you can't change those factors. But that's a very small group of the injury population. Looking at that whole journey again, so that you've got this completeness of what's going to happen. So if I use these examples in work again, there's a couple of weeks ago that one was playing like a ripper or like a touch kind of NFL game. In New Zealand, it's called rugby, but for a young woman, they don't do full tackle, so they might have ripper. Yeah.
Flag.
There we go, flag. There we go. That's what I knew there was some kind of connection. So they're playing flag, and this young woman tried defensively catching an opponent, and then her leg had this classic stopping, twisting, popping, snapping, couldn't walk off the field scenario. It took her about 3 weeks to come and see us, and I can predict what her trajectory is like. When you ask her, she's going to be coming and seeing me for it's a year journey, very much. When you ask her what her goal is, her identity is with her team. It's really, really important for her that she's with her peers. She loves playing these sports. That's really, really important for her, and it maintains part of her identity. It's really useful. And when you ask her, and I talk to her surgeon about it, you know, what does she want to do? She's certain, she's 100% certain she wants to go back and play flag again. That's what she wants. And that's her goal. And they all believe and think that. That's what they want. So they have an injury, this catastrophic knee injury that will alter the trajectory long term. And they are very confident they want to go back and play that sport again. The trick is, and the reality is, that not many do. So at a elite level, pro level, where people are really valuable, that they're a pro athlete, and this fits back to some of my work for the All Blacks, that these players were worth a lot as a resource, and so we would do everything we could to maintain their contract and maintain their participation. So they got seen every day. They are very competent exercisers. If they're lucky, you might get an 80% return to sport. That's at a professional elite level. Below that, for normal people, it's roughly 50%. So it's not what they expect. The expectation, this young woman, she ruptured her ACL, she's got over the trauma of couldn't walk on crutches, comes in, a couple of weeks later, she's better, it's all going okay, she's waiting for surgery in a few weeks' time, and her belief is, or her wishes and her goal is that she's going to return to play with her peers. But the likelihood of that happening is like flipping a coin. And that's with successful rehab. That's what success, that's what the trajectory looks like at the minute. I put my other hat on, that I think that sometimes our rehab could be a bit better, but that's the reality of what we see in the data, is that normal trajectory, maybe it's a 50-50. One of the really important things for people is, as time's gone on, we've become more understood and we ask better questions. So the big point was it was mostly research based on males, and then we got to decide and saw that there was a lot of young females having these injuries. And so some clever researchers thought maybe we should ask young women what they think, and they spent a bit of time researching them, which seems very obvious now. But they asked them how they feel and what the experience is like. And we use these tools called, they're called psychometric measures. And when I say a word tool, some of the young patients I see, they think it's a tool, like literally a handle. It's like a mechanical tool, but a tool in research is literally just maybe a questionnaire. But it asks you some pretty detailed questions about how you feel, or the anxiety you might have about going back to playing sport, or if you're nervous about re-rupturing again. And that is a real issue. So again, it's successful rehab. So you've had your injury, maybe a year later you want to return to sport. Half, they all do. Reality is that only half of them ever get there. These psychometric measures so that people are really fearful about re-injuring again. And to me, as a dad, I've seen this with one of my children who's had an injury, that worries me for her, because she's fearful of what she went through before. So it showed me that it was really meaningful. And so we use some of these tools with a prevention program. These psychometric measures are really important. You get to really understand how somebody feels and how it's affecting them. This does come with a nice punchline, because some of this stuff sounds a little bit negative, like this part particularly. So here we go again. My young patient, her name's Ava, who I saw a few weeks ago. She wants to come back and play. Said, okay, maybe in a year's time. She's about to have surgery in a couple of weeks' time. If she's lucky, if she's part of the 50% who get back to go and play some sport, that would be great. That's awesome. Psychometrically, I think if you prepare people well, they do feel a bit more confident about it, less anxiety, which is important. And then here's the puncher. If they go back and play sport, this is for young people, not so much a 40-year-old who wants to go skiing once a year, and that's a whole different story. But this young cohort, like my kids, like everyone here, up to between 25 and 30% of them will re-rupture again, that horrifies me. And the interesting part, I find this interesting as a scientist, but the interesting part is if you injure your left side and you get that fixed and reconstructed, and you go back and play sport, you're part of that 50%, 30% of them are going to rupture, and they rupture the other side. And so here I'm going to try to knit this all together. If I then go back a few slides ago, these modifiable factors, that strength and having coordinated muscles, particularly for young women, there's a special kind of sequence, some special sauce to it all. If you can get those muscles working properly, you can prevent at least 70% of those injuries. And we think that those people who go back and play sport after successful rehab and re-rupture the other side, they've never had some of these modifiable factors actually looked after. So these are glaring pieces of data that come out. The good part of the story, well, I've got one more bad thing to tell you about first. It's not bad, but this has no relevance when you are 13, 14, 15, 17, it just doesn't matter. But again, in my daily practice, I see the fresh injury, hobble in on crutches, swollen knee, can't walk. 2-3 weeks later, they're happy, they're going okay, they get prepared for surgery, they have their surgery. You know, in the first few weeks, so that's not so good, not so much fun, depends what kind of graft they have, that goes on for a while. They get to month 3, 4, they want to start trying to run again and be more active. They get to month 6, they think they're pretty good, they're usually not. They get to month 9 to 12 and they try and pass this return to sport. And we heard about how many of them go back, half. Then imagine that's not the end of the story. 1 year later, for some, we can start measuring. These are quite sophisticated measures. We can do MRIs and actually see this bruising pattern in the back of their kneecap. So they've never damaged their kneecap. The kneecap's fine, they broke their ligament. But we can start seeing the beginnings of some bone change behind the back of their kneecap. It's the first evidence of some sort of arthritic change in their joint. We then jump ahead, year 10, which if you are a young person, let's say my Ava, she's 17. So when she's 27, which for parents here, that's not that old, that's pretty young. When she's 27, 50% of them will have arthritic change in their joint. So without being too fine a point on it, so this is considered an epidemic. There's lots of these things happening, but behind the scenes, we talk about these young, old knees. So these are young people who have old knees. Jump forward another couple of decades. If you have a ACL injury, you can have a basic one. You can have just that yellow ligament can be broken. If you're really lucky, you get your yellow ligament broken and then you bruise some other things inside, like another piece of maybe cartilage or meniscus. And if you're really lucky, you can then hurt some of the other ligament. If you're really lucky again, you can hurt some of the bone and put a bruise on it. Those people are about 7 times more likely to have a total knee joint replacement in the future. So this injury is big. Let's extend to the bad stories, because there's some potential with this. In the late, as we started seeing more and more of these injuries occurring, and it genuinely was considered an epidemic, there was a lot more time and effort put into things. So we looked at footwear, turf. Sometimes if they were playing Astro, was too grippy, and when you tried to stop, it literally stuck your foot and that would rupture. So there's lots of these things that were happening that we didn't know about. There's even an article in the New York Times maybe a few months ago about the increase in soccer-related injuries, ACLs in both the UK and in the States. So there were lots of these things happening. So we spent a bit more time looking into why this happened, and they developed some prevention programs. So we were identifying there were some of these modifiable factors coming through, and there have been some genuinely good prevention programs implemented. And if you do them, and one of them is sponsored by FIFA, and it's FIFA branded, it's called a FIFA 11 or FIFA 11 Plus, and it's come through several iterations. There's actually a few programs that are all essentially the same. I put that picture on because on purpose to show that it's quite a lot. It's lots of little categories and lots of things to do. And this speaks to some of the problem. These things work. They'll probably reduce all lower limb injuries by up to maybe 50%. Here's the kicker. This is then plugged into a team, and the coach has to buy into it, and the players have to buy into it, and it takes some sort of maybe up to about 15 minutes. So this is a warm-up before training. And I mentioned this twice per week. And if they do that, the injury rates reduce half. It's pretty good. But when we then look at the implementation, this goes back to my beginning part, doing something, and actually you might have all the data in the world, but if it's not done, it doesn't work. And implementation of these programs is really poor. So when you've got a controlled study and you invite in a couple of teams and you can fund them and motivate them and get the coach on board and they do these things, it actually does, prevention programs are pretty good. But these are all one size fits all. It's part of the other reason why there's pretty poor uptake. And most teenagers aren't really too concerned, mine aren't, about what's in the future. I might promise them something in a couple of years' time and they're not really worried about that. They're pretty immediate. They want to think about things straight away. And so it's very, very hard to get a youth athlete to adhere, it's a specific word, to adhere to these programs. They work, but implementation is poor. And they're very, very long. And I think that's part of it. It's not very engaging, a bit boring, got to do it before training, and it doesn't stick. So let's go back to the beginning. So you have lots of these ACL injuries coming forward. I can give you all lots of anatomy about it, but these are decent injuries. They have a lifelong appeal. Even with normal outcomes, they're not all that successful. Somebody fell upon this idea of these prevention programs, and prevention programs work if implemented. Oh. And that's the sticky point. So after the last little while, we've been working on this idea, and we believe we've sorted the implementation gap. So this draws in some of my research work and some of the data internationally, and then we talk about those modifiable factors. And then I know from the young athletes I work with that their implementation is low. But if you can design a program that satisfies their adherence, they engage with it, they enjoy it, implementation isn't a problem. So sometimes it's about technology. So compared to these ideas 20 years ago, we don't have some technology there to fix, to maybe, I don't know, make people engage. So we have what's called Valve. This is a technology company from Australia. There's some other equipment they're called load cells. So these are very sophisticated electronic devices that can measure your strength. They can measure how high you jump. They can measure how heavily you land. We can use technology to measure, so the critical part, those modifiable factors. We can video and see, when we go way back to the beginning about, just for illustration, that wobbly knee. We can video that. We can measure impact forces. We can measure everything around that and literally correct it. The important part here is we use, they're called domains. So we help identify those people who are essentially self-starters. They really enjoy exercise. They enjoy exercising independently. There's not many of those. There's a few who need some peers and they want something that's engaging and interesting, almost gamifying. So sometimes having exercise streaks. We don't find these things out until we ask our teenagers. So these are some psychometric measures. So we can work out in these domains who might need some extra assistance to make sure that they become adherent. It's a really special word to me. There are two terms we use in trying to engage and improve rehab. So one's compliance, which essentially says, I might give somebody a list of things to do, like the FIFA 11, and go and do these, please. And very few people are compliant. They get bored with it. But if you can educate and support somebody and make them really engaged, they become adherent. So they understand why they're doing it. They really enjoy it. They have some autonomy. They become a long-term self-starter. We have the ability to, believe it or not, turn a teenager. This is a big claim, to turn a teenager into an adherent athlete through some technology. I can't turn my own children into adherent children. It's funny that if it comes from somebody else, they listen. But I think that's a parent thing. I think most parents can understand that part. I'm trying, but my kids just still won't listen. The they would cringe me talking about that. The other domain, so we can profile what somebody's behaviors are like. That's probably a better term, the psychometric. We can measure very, very accurately how strong somebody is. And lots of people can do strength tests, but here's where the devil in the detail is. And this is where some of the research partners, why it's quite unique internationally, that I'll just pull out some numbers. A young woman comes in and sees me at work and she's, I'm going to do this wrong way around in kilograms, 120 pounds. It's about 50 kgs. That's a pretty normal, that's pretty average weight. Yep. What an athletic young woman who's super strong should generate her body weight in some of the devices we have. I've seen them, they come in, and these are these modifiable risk factors. These are these girls who we can reduce these injury rates by more than 70%. These lifetime events. If they're really strong in their thigh muscles, that gives them some protection to what's called decelerate or shock attenuate. It helps slow down that collapsing movement. But if you're 120 pounds and you only score 40 pounds of strength, that's not sufficient. So we've got measures, we can measure those levels. And over a short period of time with proper programming, you can bring that up to a level that's safer. So we have these psychometric, we can identify what behaviors are like. We have very specific domains of strength. And then we use some video analysis and some force plates to work out how efficiently somebody jumps or how inefficiently they land and those risk factors around that. So from an implementation perspective, we can profile an individual and give them exactly what they need, not a generic one-size-fits-all longitudinal program. All the international researchers, which some of them are out of the States actually, we believe that's what's gone wrong. We have the science and the technology and the knowledge behind it, but implementation is lost. So we keep seeing this very high trajectory of ACL injuries. And we think we can tailor these things to a person, that's going to make all the difference. The missing piece, I think we talked about briefly, was the implementation part. And I think that one of my pieces of work for the last sort of 15 years is trying to modify doctors and orthopedic surgeons and physical therapists, and they're very hard to modify. And so lots of the research or the work I've been doing is about quality assuring people. This is a really important piece of our offering, that the clinicians that are involved in this project have been quality assured, they're experts that have been grilled again and again and again, so that if you see one clinician, they're going to do a certain test and the next clinician does exactly the same. That ability to become so systemized with technology is very hard to achieve. I think it's one of the really the key success points behind the program. So you can rely on the quality that you're going to receive. That's the whole ACL journey and the prevention offering we have. Do you have any questions? Some was a bit morbid to start with about injuries and they don't go that well and you're likely to break them again. But there is some light at the end of the tunnel with prevention programs. But the prevention programs we think have to be really tailored. And technology is a really important piece. So I might hand you over to Jason and maybe explain some other options around it.
We have lots of notes. I feel like she has a question. All right, I get the fun part. This is just general information, I think, and a lot of the people that have been developing these programs are behind you, but Host has been developing with these kind of like little projects, I think, inside of Host that I don't know if everyone knows about, but like we've been doing longevity testing. Brendan is behind you, who's been managing that program. We've been developing the knee program with Jeff, Luke, and Brian, and Antonella are behind you. And what we're essentially doing is putting up, like, if you want to know some stuff about your knee and your health, tons of data into a thing. This is what Jeff was talking about, where you can, let's say that you get 50 tests all for your knee, and you can use those tests to identify exactly what's wrong. And like Jeff said, let's like pinpoint it and like actually fix what's wrong instead of just guess and like do the systemize what everyone else does. So this is really exciting because this year we're going to do our first official annual summer boot camp for KneeVention. We hope to do this year over year, but this is the first one. It's going to be 8 weeks over the summer. I've got a couple dates. Okay, yeah. So 8 weeks, there's 2 different options. And the first one is going to be starting on June 22nd. That'll be starting at 3 p.m. And then we have another group starting on the 29th. So we're going to kind of stagger these. Those will be offered at 3:40 and 4:20. And I'll send all of this. Everyone's going to get an email after, so you don't have to remember all this. And you can take this home if you're here. What we're going to be doing is putting you through a whole round of testing. So everyone who signs up, you're going to go through Jeff's whole protocol, physical and psychological, developed with Jeff and Luke and the host team. And so we created this whole different test protocol and risk profile. And then once you do that, that will identify what you need to train and what you need to work on. And then we have our physical therapists, especially Antonella and Brian, who are working on this project, who are going to be your leaders and take you through your 8-week program. Currently, we have that meeting 3 times a week. This can be in person, some of it can be virtual, so we're trying to make it flexible over the summer. What's really exciting, I don't think it's been mentioned yet, but Jeff is here not only to give this presentation, but he's also been training all of our physical therapists on his like, what do you call them? Treatments, techniques, testing. I'm not a physical therapist, but he's been here teaching our team. And so what I think is really cool about this program is when you sign up and you participate, you're kind of getting Jeff's expertise, you call it, through our team and their expertise. And so you're getting this whole wealth of knowledge through the program that you won't get anywhere else. So that's really exciting. I think what's really exciting for me too is we have been working with Jeff and Luke and everyone to combine these tests, both psychological and physical, into our own proprietary health score. And we've created this app to kind of show you where you are. I think everyone at least here physically has been in physical therapy, and Jeff talked about psychology, or what do you call it? Psychology? Psychometric. And so usually when you come to PT, you'll get like a little sheet and it says like, what's your pain level when you go upstairs? And what's your pain level when you do this? And what's your pain level? And it's all just about pain, but it never says like, are you scared to go upstairs? Are you scared to hurt your knee? Are you like anxious if you walk through sand? You never get any of that. And what this will do is measure that kind of part of your brain. My foot's injured. I'm scared to like do anything because I'm just afraid it'll be painful. And usually that afraid part, that like cycle part, is not integrated into treatment. It is maybe in the back of your head, in the back of your therapist's head, but not always like, let's see a linear progression, or let's see up and down progression. And then we'll combine that with physical capacity and then the tests. And so this whole physical capacity and testing, hopefully over time, over this 8 weeks, will increase and will get you combined into this score, which will tell you pretty close when you're ready to return to sport. So this is really cool. This is what I'm excited about because I made this. What this also shows, it will produce all of your results. And so if you're seeing an orthopedist or a surgeon or someone who's interested in your progress, you can get all of this progress week to week, test over test about how you're progressing through a program. And that's really simple through here. This just shows kind of the progression of what we're starting. So phase 1 is going to be the testing. We're going to do the testing the week of June 19th, the weekend. I think it's the 19th and the 20th. Friday and Saturday. You can correct me if I'm wrong. But that will be all of the testing. So everyone who's participating, we want to do all of the testing, get all of that done. So when we start the programs on the 22nd and 29th, you're able to jump right into the training part. At the end, what we hope to do is retest and show you where you've been, where you started, and where you're ending the summer. This is, we talked about how we're gonna do it. Instead of doing one-on-one, we're gonna focus these in small groups. So think like small group training, 6 people max in each of these cohorts. Reason one is it, basically it's more fun when there's more people, right? And we can do more things. And so if you're playing a team sport and you're with just yourself, you can't really do team things because there's no one else with you. And so what we're able to do, I think this is like psychological and physical, is a more team atmosphere. The price of the whole program is $995. And I say that with this small group focus because it ends up being like 3 times a week. We're starting to bring the price down and make it more affordable and be more effective at the same time. And so if you think of like a group fitness class, very solid core, I don't know, yoga, a lot of those classes are like $40 to $45, sometimes $50. And we're trying to kind of keep it at that level. So it's not just like a crazy expensive thing. And the goal is to get a lot more value from this. And then we talked about in-person 3 times a week. If we need to do some hybrids, virtual, definitely we can coordinate that as well. Any questions for me? Amazing. I'll send you an email with all the details. And if you have any questions, just give us an email.
I see it says testing only options are available.
Yes,
So you could just come in and take testing.
correct. So people on that, if you just want the testing, you can just come in just to get the test and get just the initial results.
Which would indicate how vulnerable you might be.
Correct. So all those factors that are shown to be correlated or connected with injury, that's essentially what we look for, all of those. And then at a personal level, we can identify which one. And on the dashboard, it literally gives you a ratio, what factors are the most risky for you for injury, and then how you'd address those.
Will this be offered, maybe in a different format in the fall? Like you're leaving behind disciples to do your work, right?
Yeah, this is the joys of technology. So I have lots of, my work is quite unusual. So it's less than 1% of clinicians in New Zealand are specialists. So lots of my work is virtual. So I have a research lab, which looks like a dungeon. It doesn't have a natural light, but it has video and a whole lot of testing equipment, and I'm quite proficient. I end up working really weird hours to fit some of the people I see overseas. And so that's some of the mentoring we do here, making sure, so the really important part to me is that things are standardized. And in science, it's really important that we are doing the same thing again and again and again, so you can kind of guarantee and rely on it. So part of my job is working virtually. That's the short end of the answer. So it's like I'm here, but not here. Yeah. Might have some late nights or early mornings. I'm not too sure which way it goes. Yeah. But it's good though. It's good fun. Yep.
I think we'll learn a lot over the summer too. And so if there's demand in the fall, then very good chances.
How do you scale this, but thinking about it from a public health perspective?
This is what they've been trying to do. That they've looked to scale at an easy rate, and that's where these prevention programs came in. So this is the FIFA work, and FIFA are worth like that's about a $500 billion company. Like that, these guys are highly motivated to look after their participants, and they haven't been able to do it. So they've thrown heaps of money at it, and you try and incentivize and encourage coaches. But what happens is it becomes diminished really quickly. They just don't see the end result. So sneakily embedded into this is the cooler kind of wording, I think, for my kids, is that injury prevention is not a great thing for my teenagers. They don't want to know about that, but they want to know about performing better. So encoded in this work, they become a faster better accelerating, better decelerating, higher jumping. They become a better athlete. That's actually what motivates most of the athletes. And that's what you don't get in those other prevention programs. And I think that's why they keep calling them kids. That's why teenagers don't really want to engage with it. That's why the scaling hasn't really worked. Teenagers are a really unusual group. They challenge things and they aren't always compliant. They're very minimally adherent. We're to try to find something that motivates them. So I think that's where scale's been difficult. Those are good questions. Any other?
So this is a lot. Summer's busy too. Summer's always busy, and these kids are busy. Let's say we did the testing. Is there another way of addressing any of the issues that were identified here, but maybe not in such a rigid format that's this summer? Is it if we did the testing, is there a way to use that information without committing to all of these sessions this summer instead of just wrapping down?
Especially one that we believe there's some virtual options. The trick is if you want to try to make somebody faster, decelerate, make all these things better, optimally, minimally, you'd need to do 2 sessions per week. Otherwise the body doesn't adapt. Ideally, you'd have at least 1 session physically present, because I think that the clinicians can be a lot more reactive and accurate about making changes. So you can guarantee you're getting money for value. These things are getting better and better and better. And then we do have some options. We haven't been confirmed yet about a virtual component. So that's where apps and technology can monitor teenagers, it can monitor people, and it can cue them for exercise. And we've got some video analysis on there that actually they could complete some of these things not here physically present. So although the course might still seem, 8 weeks, you may be doing a couple of those sessions at home or somewhere else. The composition is the really important part, and that's informed from the baseline testing. That's the key part. It's really good.
Thank you very much, Jeffrey.
You're welcome. Welcome.
If anybody has any questions, please feel free to reach out to us. To just address your question, fundamentally, I'm sure you've heard frequency, intensity, one time. Those are the types of training. So Jeff says you've got to do twice a week plus. We can try and modify times and or potentially the video to send that to you, but we don't do this thing. Quite with the level of data that we're going to be collecting, it's going to be very comprehensive. Ideally, you want to motivate people to show that they can do this, which does require the time. And be modifiable, but modifiable to an extent.
I think one of the really important things we want to try to stress people in a positive manner, and I think that really key for adherence for teenagers is they need to see success and success really quickly. And so some of the exercises we do, they see improvement very quickly, and that's very encouraging. And then they're more likely to adhere to it. So if they don't get enough doses, it doesn't really work so much. So the whole system might stretch out a little bit over time. It could go out by an extra couple of weeks, but I think that success is really important. They need to stay motivated. And that's where some of the preliminary work and some of the other research sits. Great questions, though. It's good.
Thank you, Jeff.
Welcome.
Thank you, everybody.
Welcome. So it's not all morbid information. There is a positive